Hello, my name is Annie Lee and I will be presenting a policy advocacy pitch focused on improving childhood obesity through nutrition-related interventions within U.S. schools. In today's presentation, I will be providing key elements from the policy brief outline of policy evaluation and recommendations. The objectives of today will be to gain a better understanding of childhood obesity, address the role of schools in combating the epidemic, and advocate the implementation of nutrition-related intervention in the U.S. school system. According to the Mayo Clinic, childhood obesity is defined as a serious medical condition that affects children and adolescents. But what is not highlighted in this definition are the social, economic, and ethical ramifications that come with this preventable public health issue. According to the U.S. Centers for Disease Control and Prevention in 2018, 23.5 million children and youth were obese in the U.S. That equates to about 1 out of 5 children. More than 3 million new cases have occurred each year, and prevalence and incidence rates remain high. In addition, incidence is disproportionate in groups such as low-income families, Hispanics, and non-Hispanic Blacks. As a result, childhood obesity continues to be a preventable public health epidemic in the United States. And internationally, according to Newsweek, the United States has had one of the highest prevalent percentages of childhood obesity when compared to the top 100 most populated nations in the world. In 2014, a total of 55.6 million U.S. children were enrolled in an elementary or secondary school, but only 2% of these school-aged children had consumed recommended servings from the food guide pyramid. It is also found that 99% of high schools, 97% of middle schools, and 83% of elementary schools have either a student store, snack bar, or vending machines that distribute high fructose fruit drinks and high-fat snacks. This shows the impact that schools have on childhood obesity. About 18.5% of school-aged children are obese, totaling about 13.7 million lives in the U.S. Obese children also have been found to have 4 times more academic issues compared to their healthy counterparts in school. Access to education up to the 12th grade is free within the United States, and childhood obesity prevention within this environment will ensure that ethical issues of maximizing benefit for all through reducing the morbidity and incidence of obesity. Research has shown that childhood obesity contributed to an addition of $19,000 in incremental lifetime medical costs when compared to maintaining a healthy weight throughout adulthood. Overall, if childhood obesity trends continue, annual medical costs associated to obesity can rise from $48 to $66 billion by 2030. The loss of economic productivity secondary to childhood obesity has also been estimated to reach up to $580 billion by 2030. But analysis of direct childhood health expenditures in research showed that interventions in the prevention of childhood obesity yield effective reduction of excess spending. According to the RAND Institute, a survey conducted amongst 10,000 people in the U.S. showed estimated healthcare costs associated with obesity to be higher than other health-related issues, including smoking, aging, problems drinking, and being overweight. Multiple departments, including the CDC, USDA, and HHS, have all been involved with government legislators in supporting and implementing a variety of acts, laws, and initiatives on a federal level. These include the Child Nutrition and WIC Reauthorization Act, the Healthcare Reform Act, the Healthy Hunger Free Kids Act of 2010, and today, the Healthy People 2020 initiative, which has highlighted and recommended in their objectives to reduce childhood obesity by 10% in the year 2020. Yet states and local governments are still left to develop their own initiatives and programs for childhood obesity. This chart outlines state policy initiatives that have been enacted in regards to targeting school interventions toward childhood obesity. As you can see, they vary drastically from state to state, and a lot of states have actually not attempted to develop any initiatives to address this issue, which may be contributing to the continued rates of prevalence and incidence in the US. 4 primary criteria for evaluation were provided in the policy brief outline. They include economics. Will the policy intervention improve childhood well-being? Epidemiology. Will it reduce morbidity and mortality? Equity. Will it provide social equity? And public perception. Will it provide improved health outcomes? The following 3 alternatives to policy intervention will be addressed, with some key points in support and refute for each will also be mentioned. The status quo, which will maintain a pre-existing broad approach of federal and state guidelines through financial support, promoting general regulations for school meals, removal of competitive foods, which entails removing any unhealthy foods and beverages that are not federally approved in school, and lastly, nutrition-based seminars aim to provide preventative education on healthy nutrition in schools. Now we will analyze each and highlight a few of the evaluation criteria. Current approaches of childhood obesity provide general federal fundings and guidelines for states and schools to utilize in interventions. Continuing the current legislation would allow for sufficient nutritional meals to be provided, but other types of interventions are left at the discretion of states and schools. Current federal funding and support of diet interventions in schools show moderate strength of evidence in childhood obesity prevention. Yet, this alternative does not provide targeted resources for at-risk populations, nor efficient impact evaluation to address childhood obesity. Despite current legislation, there has been no statistical decline of evidence rates in any of ages within the last 8 years. Alternative number 2 is competitive food reduction. Federal funding and federal funded schools have to meet federal nutritional standards, but competitive foods do not abide by the same standards. By requiring schools to remove or limit the number of competitive foods sold in schools, children will not have access to poor diet choices. But the removal of competitive foods will reduce a source of income for schools. In addition, competitive foods are only one factor contributing to childhood obesity, and removal does not guarantee that it will have a direct effect. The third and chosen alternative is the nutrition-based seminar. Research has shown that prevention using health education positively influences diet choices and reduces health risks contributing to childhood obesity. By requiring a nutrition component in school curriculums, children will attain education to develop healthy behaviors in food consumption. Grant funding from the healthcare reform will also be utilized effectively and efficiently through a tangible intervention. And through health education, the benefits of a reduction of prevalence and incidence of childhood obesity will yield less medical costs and overall burden on the individual and the nation. But implementation of new curriculum will require increased resources and reliance on outcomes from previous piloted programs, which have limited sample sizes. Because childhood obesity is such a complex issue, immediate and impactful reduction may not be conceivable. Given the alternatives, the final recommendations for addressing nutrition to improve childhood obesity rates within the U.S. schools is implementation of targeted nutrition seminars in a school curriculum. This alternative builds on the preventable efforts that are already incorporated in healthcare reform while addressing the components that are lacking in the status quo. The following combat steps are recommended for implementation: consumer needs, addressing community needs and demographics; opportunities to lead, composing a group of leaders from the school and communities to motivate and carry out interventions; measures through goals and benchmarks; build and propose a sample seminar; apply and secure funding from federal and state grants; and taking steps to implement the curriculum, as well as assess efficiency and effectiveness. 2 limitations need to also be addressed in implementing these policy interventions. Healthcare reform has allocated federal funding to implement preventative measures, but with the changes of administration, the future of healthcare reform funding is jeopardized. In addition, limited research-based evidence of best practices are currently an issue because piloted programs have shown successful health interventions that target only their specific populations. So this will require extensive research, time, and funding for new programs to be implemented at new locations. Though public and government interests have prioritized obesity in recent years with funding and resources, the prevalence and incidence rates continue to increase. As a result, we need to equip schools and equip children with the correct information and correct utilization of education in order to overcome childhood obesity. Thank you very much. These are references.